Thank you, Myra. Thank you for giving me a chance to speak as well, and Healthy Philadelphia for organizing what I think is a very important and meaningful discussion of an area of care that even at an outstanding hospital like Penn, we don't do such a great job with, and that's transitions of care. I don't think it's malicious. I don't think we aim to do a poor job with transitions of care. But I think there are some areas where there's a lacking of understanding, both on our part as physicians and nurses, and on our patients' part as well. I'm going to cite 3 areas that I think there's a lack of understanding. And again, because I think this isn't done from a sense of maliciousness, I'm going to cite some of my own mistakes in taking care of patients. I am now a hospitalist at Penn. I've been in training for 6 years. I'm now an attending, a professor. I can say my first week as an intern, I didn't know all that much. I know a little bit more now, but not a tremendous amount more. But yet, I as an intern, and all the interns who have followed me, are the ones who are responsible for a lot of the transitions of care that our patients go through. And let me give you some examples. So the first areas of what I didn't understand on transitions of care. I took care of a patient who was admitted with a new diagnosis of diabetes. And we did a lot to stabilize the person's blood sugars, a lot to try to connect them with the kind of health care they needed post-follow-up. And I think I and my team did a good job with that. But then there are so many details of what it takes for a person to have that same kind of treatment at home that we provide in the hospital that I think it was hard for me not to screw up. And I did screw up. So to start somebody who is a new diabetic on insulin, it's not just the insulin you have to prescribe, but it's the needles and the syringes, and you have to take into consideration what the person's eyesight is like. Can they even inject the insulin themselves? And this is a true story. So I sent the person home, new diagnosis diabetes with insulin, and they didn't really understand how to inject the insulin. So what they ended up doing was going through and through their skin. So as they injected the insulin, instead of going subcutaneously, it was going out the other side. And that's such a small detail, but I, as an inpatient physician especially, it's a detail that I kind of miss in what I think is the bigger scheme of taking care of a patient. But it's a mistake that led to that person being rehospitalized very soon after. And these mistakes aren't isolated. In talking to friends and colleagues, the number of patients who are sent out after major operations with staples still in or stitches still in. Again, what we consider minor details, but very tough for patients to take care of at home. So those are lack of understanding on my part, other physicians' part, on some of the challenges for what it takes for a patient to be at home. But add to that some of the challenges in transitions of care for the uninsured. And I can tell you that as a new intern, even as a senior resident at Penn, I had no idea what a federally qualified health center was, no idea what Medicaid was, no idea what the health districts were about. This is something that we're not taught. Nowhere in our medical training is this something that's emphasized. So even if I wanted to get my patient optimal care, just context of what I do in my spare time. Now, I do a lot of clinic work for the uninsured. This is something I'm passionate about, something I believe in. But that said, even as an intern and a junior resident and a senior resident with the best intents, having no idea what was available, you can guess how often I referred a patient who was uninsured to an FQHC or a health district, or started the Medicaid process for them. The numbers were probably in the single percentages. And even now, if you were to quiz interns and residents on the wards, the number of them who would be able to tell you the difference between an FQHC, health district, what it takes to get Medicaid, is probably an exceedingly small number. It's just something that's not taught. So if we don't understand it, how are we going to refer our patients to the right place? So the first 2 areas of misunderstanding, more on my part as a physician. What I'll end with is the areas of misunderstandings on my patient's part. The things that I've seen with patients, not in hospital, but outside of the hospital. One of the free clinics that I work with is affiliated with the University City Hospitality Coalition. It runs every Wednesday night in a church basement. We largely see a homeless population who fall below the poverty line, a fair number with HIV, psychiatric conditions, the vast majority of them have Medicaid. They have full theoretical access to healthcare coverage. And that's a difficult process to go through, having gone through with many of my patients. They've gotten all the way through that process to the point now where they have some of the best medical insurance that they could possibly have, and they're seeing me in a fairly rundown, ramshackle clinic. So why is that? Especially on the patients who I see with HIV. I would say on an average clinic night, I'm seeing at least one patient who has an HIV diagnosis, has Medicaid, knows of the need to go on to heart therapy, but isn't. And why is that the case? Again, it's the idea that access isn't the only barrier to patients getting proper care. We do an even poorer job of explaining how you then get an appointment with an HIV doctor or a primary care physician. Again, it's something we don't think about. And even at this clinic that's seeing those patients who have Medicaid but aren't seeing a primary care doctor, it wasn't even a part of the visit to then counsel patients on how they find a primary care doctor. It's something we're working on, but I think the best way to educate us and to get us to educate our patients is forums like this, for us to understand all the things we don't know, understand all the mistakes that we're making. And I think that's why this is a great step, and something I'm certainly going to take back to the people I work with, especially interns and residents. Thank you.